We have started discussing about the lymphatic system, and particularly in the previous lecture, we have been discussing about the lymphedema and the anatomy of the lymphatic system, the channels, and the pathway, the function, and how actually the lymphatic system is helping to drain the lymph into the larger veins of the body. We discuss about the primary and the secondary lymphedema in a superficial way, but today more precisely and more comprehensively we'll be talking about primary and secondary lymphedema in detail. So let's move on to the lecture. Sorry about the bad voice, you guys have to bear me with that. So if you could appreciate in the diagram, I hope and I believe you all are familiar with this kind of a picture, which was also shown in the previous lecture. This is about the primary lymphedema, and it usually develops as a generalized swelling most of the time, commonly starting from the pedal part and extending proximally as compared to the distal to proximally. So most of the time, because the factor of the gravity, you cannot ignore the factor of the gravity, and most of the time the gravity is pulling the fluid to be in the lower limbs. So because of the effect of the gravity, this is most of the time lymphatic system of the lower limb is most commonly affected. So if you could appreciate in this diagram, actually there's a kind of a skin changes as well, the redness, and a swollen limb. Sometimes it can be unilaterally and sometimes it can be bilateral, but specifically, if you talk about the primary lymphedema, then the cause behind the primary lymphedema is either unknown, or usually it is considered that this is actually the congenital hypoplasia of the lymphatic system or dysplasia of the lymphatic system. Usually, at times, the patient may present early, right after the birth or within the 2 years of the birth. And sometimes it may take a lot of time, and patient may report to you in late 30s or late 40s. But if you cannot identify the cause, like there's no reasonable cause, no radiotherapy, no history of like surgery to the lymph nodes or malignancy associated with the lymph nodes, then you have to think about the primary lymphedema. So either you consider it that there should be a cause behind that, but you actually the cause is unknown to you and you cannot figure it out what actually the cause would be. So that condition is called the primary lymphedema, and it is usually considered that this is because there's some kind of congenital problem, inherited mutations that leads to the development of the hypoplastic or dysplastic lymphatic system, and later on, because of that, there's obstruction and there's stasis of the lymphatic fluid, and because of that, it leads to the development of the primary lymphedema. So, talking about the etiology regarding the primary lymphedema, there can be inherited abnormality. Sometimes there are familial cases, sometimes there are sporadic cases, right? So the familial cases, most of the time, they are because of the mutations. And sometimes, like it can be a Milroy syndrome, or it can be Noonan syndrome, or it can be like, tuberous sclerosis, in which there is some kind of mutations with the vascular endothelial growth factors, or they're kind of the FLT2, which are basically FSM-like tyrosine kinase receptors, and there may be some kind of abnormality. Sometimes there can be familial cases, there can be sporadic cases. So what do you mean by familial cases and the sporadic cases? So actually the familial cases are the kind of the lymphedema which is running in the families, and because a particular mutation sometimes is inherited, so usually most of the time there's inherited mutation in the vascular endothelial growth factor. Or sometimes there's a mutation in the FLT2, which is the FSM-like tyrosine kinase receptors, and there can be mutations with that. So there's some kind of the syndrome like the Milroy syndrome, or there can be tuberous sclerosis, or there can be a Newton syndrome, in which mutations usually around these factors. So the familial cases are those in which the lymphedema is running in the families, and a patient will typically come to you, and he's going to give you the history that my grandparents or my parents, they actually had this kind of a similar picture are reported in their families. But sometimes the patient won't be giving you the familial history, and it would be a sporadic case, like only one member of the family who has developed. But you cannot you cannot say that it's not a kind of a mutation. Sometimes the mutations are being inherited, and sometimes the mutations are sporadic. Like the patient develops these mutations in the process of the gene transcription, or the gene the translation. So sometimes you have to keep in mind inherited abnormalities are mostly the familial cases, and they usually, because of the mutations or abnormalities with the vascular endothelial growth factors, or these can be in the FSM-like tyrosine kinase receptors. So the other thing is a congenital lymphatic dysplasia. So there's actually congenital dysplasia, or the hypoplasia of the lymphatic system. So obviously, when there's a dysplasia or hypoplasia of lymphatic system, then these things actually they lead to the decreased function of the lymphatic system, and because there is decreased efficiency in functioning of the lymphatic system, so because of that, there would be stasis of the lymphatic fluid in the lymphatic channels, and that would actually affect the process of drainage. And because of that, the stasis would ultimately lead to the dilatation of the lymphatic system, and the patient will actually present to you with a primary lymphedema. Sometimes there's another thing, which is like the chronic cases of the lymphedema. You also, some of the group of the people, they classify the trivial injuries, and especially the repeated trivial injuries in a case of the primary lymphedema, like the bacterial infections, like the fungal infections. But usually, all those patients who develop some kind of a bacterial infection or some kind of fungal infection, lymphangitis or lymphadenitis, they do not develop their lymphedema. So it is, considered that those people who develop lymphedema after the bacterial infection or the fungal infection, or especially the lymphadenitis and the lymphangitis, they actually have some kind of abnormality. It can be inherited, it can be familial, it can be sporadic. So they have some kind of inherited problem with their lymphatic system, and after there's a problem in the development of the collateral, because whenever there's a kind of the infection, ultimately there would be enlargement of the lymph nodes, right? So there would be lymphangitis or lymphadenitis, but all of the patients would not develop the lymphedema. I hope you guys are getting my point. That means that usually there are multiple types of the infections, and most of the time associated lymph nodes, they are enlarged. There's sometimes of the bacterial invasion to the lymph nodes, and there's a kind of a lymphangitis or lymphadenitis associated with that particular infection related to that particular organ. But all of the patients who have some kind of the infection, they do not actually develop lymphedema. So it is considered that there is some kind of abnormality in the lymphatic system. It can be congenital, it can be sporadic. So those patients, they are more most of the time prone to develop the lymphedema after the lymphangitis or lymphadenitis. The other important thing need to be discussed is the insect bites, and sometimes again the phenomena would remain the same. Again, insect bite, obviously, it's a kind of the parasitic infection. So there would be obviously enhancement or the overfunctioning of the immune system and eosinophilia as well. So these patients can also develop the primary lymphedema. There's another thing which is somehow very much important, is a barefoot walking, right? So particularly talking about the barefoot walking, sometimes it happens that those patients are exposed to the silica. So actually, the silica particles, they are very, very dangerous to the lymph nodes or the lymphatic channels, and they actually damage, they cause a trivial injury to they're being absorbed by the skin surface whenever the patient is barefooted. So they just get entry into the lymphatic system, and whenever they get entry to the lymphatic system, ultimately they reaches the lymph nodes and they reaches the lymphatic channels, and they actually develop the lymphedema. So the silica particles are usually absorbed in the patients who walk barefooted, and most of the time this is common in the population, especially the African population, in which the most of the time there is eruption of the volcanoes. So in which the people who are working in that particular environment, they are exposed to the silica particles, and usually who are actually working with that soil barefooted, they actually absorb that silica into their body, and this silica or the silicon particles, then they damage the lymph nodes badly, and they would lead to the decreased functioning of the lymphatic channels. Plus, they can also lead to the obstruction, and ultimately there would be stasis, and stasis will lead to the primary lymphedema. So there's another condition which is called as the deep vein thrombosis. Either it's a superficial venous thrombophlebitis or it's a deep vein thrombosis. Usually, whenever there is a kind of a thrombosis, along with that, either it's a case of a superficial venous thrombophlebitis or it's a case of the deep vein thrombosis, they actually prone the lymphatic channels for the lymphedema and the stasis. So etiology includes this factor as well. Again, the same thing, episodes of the superficial thrombophlebitis, and whenever you are doing some kind of manipulation with the lymph nodes, either it's a simple excision of the lymph node or there's a case of lymphoma and a radiotherapy is being given to that particular organ. Or in case of the breast surgeries, usually after for the CA breast, and after the excision or doing the radical mastectomy or complete mastectomy, usually the patient is put on chemotherapy and the radiotherapy. So usually these patients also develop lymphedema whenever the radiotherapy is given to that particular site, or after the axillary nodal dissection, the patient also develop the lymphedema. And loss of veno-arterial reflex. Now, this is somehow very, very much important, especially in case of the lower limbs. Now, there can be a question in your mind why lymphedema is involving the lower limbs more commonly as compared to the upper limbs. So why? So this is actually the answer of your question. That is the loss of the veno-arterial reflux. Now what happens is, like we all know, that most of the time these veins, they have kind of the valves and they control the the movement or the flow of the venous blood. So sometimes what happens is, like, these veno-arterial reflexes, they actually maintain the flow actually just limited to the upper limb, and the drainage of the fluid from the lower limb back to the the thoracic duct. And it's actually helpful in moving the lymph in opposite direction against the gravity. Okay, this is a very, very much important concept which you need to understand. You have the lower limb and you have the upper limb. So usually what happens is veins are draining or collecting the blood from the lower limb, and they're pushing this venous blood into the right atrium of the heart through inferior vena cava, right? So it's actually the direction of the flow is actually against the gravity. So same thing happens in case of the lymphatic channels. We know that there's a unidirectional flow of the lymph from the lymphatic channels, and this is against the gravity. That's from downward to upward, and ultimately they drain into the subclavian and the thoracic duct. Now, this is important that there's a kind of the veno-arteriolar reflex which is present, and whenever this reflex is present, there would be pooling of the blood back into the lymphatic channels because of that. Because whenever the lymph is actually flowing from lower limbs to the upper limbs, it's against the gravity, and this intact reflux is very, very much important to keep the flow of the lymph unidirectional, and it avoids or it prevents the back pooling of the lymph into the lower limbs. So whenever this veno-arterial reflex is gone or is lost, whatever the reason may be, there would be the back pooling of the lymph into the lower limb channels, and their drainage would be affected, and obviously there would be stasis. So this reflux is somehow very, very much important. In case of the veins, it's also important. In case of the lymphatic channels, it's also important. The reason being because the flow of the blood is against the gravity, the flow of the lymph is against the gravity, so the intact function of the valves and the intact arteriovenous reflux is somehow very, very much important. So one thing you need to remember is the primary lymphedema is the condition in which the cause is either unknown, or you consider that the cause may be because of the congenital lymphatic hypoplasia or because of the congenital lymphatic dysplasia. And sometimes you also include another entity into this, and the entity is the repetitive bacterial or the fungal infections causing the lymphadenitis or lymphangitis, and ultimately there would be destruction of the lymph nodes, and this usually happens in the patient who has some kind of inherited mutations in their lymphatic channels. So remember, this is the etiology for the primary lymphedema. Regarding the classification of the primary lymphedema, there have been so many of the classification system devised, but so far none of the classification system is usually generally accepted as the classification series. So on the basis of the division, the genetic susceptibility, or the age of the onset and everything, we usually classify these on the basis of the genetic susceptibility into the familial cases and the sporadic cases. So if you talk about the genetic susceptibility, it has something in a simple manner, in a simple way, it's something to do with the genes, or there is kind of the mutation with the gene. It can be a familial case, it can be a sporadic case. In case of the familial cases, it can be a Milroy disease, in which the patient usually present with the lower lymphedema right after the birth. In case of that, it can be a tuberous sclerosis, or it can be a Noonan syndrome. So you should keep this thing in mind. The genetic susceptibility can be familial, or it can be sporadic. Now, another important category which we have added in the classification series is the age of the onset. So actually, on the basis of age of onset, we classify this into into three categories. One is called the lymphedema congenita, other is a lymphedema pericox, and the third one is a lymphedema tarda. So lymphedema congenita is actually it's usually up to the 2 years, right after the birth till the 2 years. Most of the time it is common in the males, and it's usually is bilateral. If we talk about the lymphedema pericox, so in that it's usually unilateral, and it's more common in the females, and it's the age of the onset is usually 2 to 35 years. And most of the time, it's more common in the patients or in the women who are obese, or they are near the age of their menarche. Lymphedema tarda is the kind of the lymphedema in which the age of the onset is greater than 50 years. Then there's another classification which is regarding the lymphangiographic classification, like in which actually there is a kind of the investigation which is called as a lymphangiogram, and on the basis of the lymphangiogram you decide that it's a congenital hyperplasia, or it's a distal obliteration, or it's a proximal obliteration. Obviously you cannot judge it by the naked eye without investigating the case. So actually, there are so many of the classification systems which were followed in the past, but as a rule, there's no well-defined classification system to be followed in case of the lymphedema. But just for our ease, we divide this on the basis of three things. One is a genetic susceptibility, the other is the age of the onset, and obviously the third classification is on the basis of the lymphangiographic presentation, right? So in the genetic susceptibility, it can be familial case, it can be sporadic cases. I also told you some of the diseases or the syndromes which are involving this. The age of the onset is somehow very, very much important. One is the congenita, in which the patient usually reports with a bilateral swollen lower limbs in age of the onset, usually after the birth or before the 2 years of the age, and it's usually more common in the males. There's another condition which is a lymphedema pericox, and it's more common in the females, almost 3 times more common in the females as compared to the males, and it's usually unilateral, not bilateral. And it's more common in the females of age 2 to 35 years, and more commonly in the age of the menarche or in the obese patients. And there's another condition which is called as tarda, and in case of the lymphedema tarda, it's actually the age of the onset is greater than 50 years. There's another classification which is lymphangiographic classification, and you actually do the lymphangiogram, and on the basis of the obstruction or the condition, you actually divide it as a congenital hypoplasia, distal obliteration, or the proximal obliteration. So again, you can see that this is a case of the lymphedema, and it's usually unilateral. And if you could appreciate, here's a lymphangiogram, and actually this lymphangiogram is showing the congenital hypoplasia, right? So this is the these are the lymphatic channels, but if you compare this side with this side, there is congenital hypoplasia of the lymphatic channels, which is obviously visible in the lymphangiogram. There's another picture which is actually showing, it's a kind of the lymphangiogram, and you can actually appreciate the hypoplasia. So there's one of the classification which is called as the lymfangiographic classification, and you actually you say if there's a proximal obliteration or the distal obliteration. It's a case of the congenital hypoplasia. So far, this was about the primary lymphedema, and obviously, in case of the primary lymphedema, there's some kind of the specific management and the treatment options. But we will be discussing the proper investigation and the management in our next lecture. But today we're more focused on the classification and the presentation. So there's another condition which is called a secondary lymphedema. So there's grossly, if the cause is unknown or the cause is because of the congenital hypoplasia or dysplasia of the lymphatic channels, then this is primary lymphedema. And secondary lymphedema is obviously the lymphedema in which, because there's the cause is known, right? There can be the lymphedema develops because of the radiotherapy, because of the lymph nodal excision, because of the chemotherapy, or because of the the trauma as well, and some kind of the bacterial and the fungal infections. So this is about the secondary lymphedema. So actually, just like we divide the primary lymphedema into different categories on the basis of like age of the onset, and we divide on the basis of the lymphangiographic classification, and we also divide on the basis of the genetic susceptibility. So same happens with the classification of the secondary lymphedema, and most of the time either it can be because of the malignant disease, and usually, if we talk about the malignant disease, then there can be some, the lymph, there's metastasis to the lymph nodes, or there is lymphangiosarcoma, or there's a Kaposi sarcoma. Most of the time, or there is metastasis to the lymph nodes. There can be infiltrative carcinomas, or they can be lymphoma, and sometimes because of the pressure from the large tumors, there can be lymphedema. So one category in case of the secondary lymphedema classification is a malignant disease. The second important thing is infection, and it can be, erysipelas, it can be cellulitis, it can be lymphadenitis, it can be lymphangitis, it can be tuberculosis, or it can be filariasis. It can be because of the inflammation in case of the rheumatoid arthritis, in case of the dermatitis, psoriasis, sarcoidosis, which are actually the chronic inflammatory processes, or they can be dermatosis with epidermal involvement. Now, there's other important things like the endocrine diseases, and usually they also lead to the development of secondary lymphedema, like the periorbital myxedema. So you have to keep that thing in mind. So regarding the classification, the secondary lymphedema, we actually broadly divide into four categories. One is the malignant disease, the other is infection, the third thing is inflammation, and the fourth is endocrine diseases, right? So malignant diseases are mostly involving the lymph node metastases, infiltrative carcinomas, involving, invasive, and they're involving extensive involvement to the adjacent lymph nodes. Like there's a difference between a lymph node metastasis, and there's a difference between the infiltrative carcinoma. So what do you mean by the lymph node metastasis? Actually, that there was the primary tumor was somewhere else, and there is a metastasis to whole of the lymphatic system, or the different kinds of the whole of generalized lymphadenopathy, or there's a lymph nodal involvement. The other thing is the infiltrative carcinomas. So always remember, the infiltrative carcinomas mean those carcinomas which are involved in the primary tumor, and the nodal, the status is the sentinel nodal involvement, or extensive involvement in case of the infiltrative carcinomas. Lymphomas, obviously, the site of the development of the lymphomas is actually the lymph nodes, and there can be large tumors, and the pressure from the large tumors, they cause the lymphedema, because obviously there would be pressure and there would be obliteration, or kind of the obstruction to the lymphatic flow, and it leads to the lymphedema. Infection is somehow very, very much important. They can be cellulitis, there can be lymphadenitis, there can be lymphangitis, filariasis, and tuberculosis is somehow the infection which is leading to the secondary lymphedema. If we talk about the inflammatory condition, then obviously autoimmune diseases like the rheumatoid arthritis, dermatitis, psoriasis, sarcoidosis, dermatosis with epidermal involvement, they also cause a kind of the lymphedema. Now, if we talk about the endocrine disorders, most commonly, this is the hypothyroidism. It's a kind of endocrine disorders plus the autoimmune. So in that category, there's a tibial or periorbital myxedema, and sometimes there's a periorbital myxedema. So all these lead to the development of the secondary lymphedema. So we can also classify the secondary lymphedema on the basis of the causes. They can be trauma and tissue damage, like they can if you are doing a lymph node excision and post-operatively, the patient can develop lymphedema. Radiotherapy, like after the surgery for a particular cancer, radiotherapy is being performed, or the lymphomas, like these tumors. They are more responsive to the radiotherapy. So all the tumors in which the radiotherapy is being done, there can be kind of lymphedema, burns, varicose vein surgery, and large circumferential wounds. Obviously, they can also lead to the development of the secondary lymphedema, and obviously the scarring, the fibrosis, because in scarring there's not only the scarring of the fibrous tissue, but sometimes as a result of the scarring there is fibrosis, and this fibrosis sometimes is involving the lymphatic channels and the lymph nodes, and obviously there would be obliteration and damage to the normal functioning of the lymphatic channels, and obviously the patient will develop the lymphedema. Venous diseases, I have already discussed about them, like deep vein thrombosis, superficial thrombophlebitis, chronic venous insufficiency, venous ulcerations, post-thrombotic syndromes, intravenous drug abusers. They are also the causes for the development of the secondary lymphedema. Now, another entity which is somehow very, very much important and need to be discussed is the mobility and dependency. Most of the time, those patients who have a sedentary lifestyle, they're immobile, and usually most of the time they are they're sitting. The pooling is in the lower limbs, and because of the venous pooling or stasis in the lower limb, actually they develop the secondary lymphedema. So remember the malignancy. Remember the tissue damage or trauma. Remember some kind of handling with a lymph node, some kind of intervention with a lymph node, some kind of surgery, radiotherapy, venous diseases like venous ulceration, chronic venous insufficiencies, and post-thrombotic syndromes, or superficial venous thrombophlebitis. And sometimes those patients who undergo the amputations or orthopedic surgery, or they have developed stroke in their life, and they're mostly bedridden and they're immobile, they also, there's a stasis of the fluid, and ultimately they would be developing the lymphedema. And there can be sometimes fictitious lymphedema, and because it's a kind of including a self-harm. So if we talk about the secondary lymphedema, so we'll be talking a little bit about the filariasis, elephantiasis, and endemic elephantiasis, right? So if we talk about the filariasis, it's somehow very, very much common cause of the secondary lymphedema, and it's more common in Africa, it's more common in India, and some portion of the South America, and it's almost affects 100 million of the population worldwide. It has already affected almost 100 million of the population worldwide. So the cause behind the filariasis is the organism which is called as a Escherichia bankrofti, and it usually is transmitted through the mosquito bite, and it's more common. The only host of the Escherichia bankrofti is the man. So actually, it reaches the lymphatic channels through the blood, and ultimately it would start damaging. So the two mechanisms that cause kind of the destruction to the lymphatic channels is actually one because of the direct tissue damage by this organism, which is called as Escherichia bankrofti, and the other is immune mediated, because obviously it's kind of the parasitic infection. So whenever this organism get entry into the lymphatic channels, there would be release of cytokines and the interleukins and macrophages, and obviously it would be a kind of the immune mediated phenomena as well, and direct tissue damage to the organism. So you can appreciate here in this diagram that this is actually the marking, and this is the localized presence of the Escherichia in case of that. So if we talk about the acute filariasis, how would the patient is actually going to present to you? There is acute filariasis and there's a chronic filariasis. So talking about the acute filariasis, the patient will develop high-grade fever, and along with that, the patient will have a headache, malaise. It would feel so much of lethargic, and there would be inguinal and axillary lymphadenitis. I would say because after coming into the bloodstream and entering into the lymphatic channels, obviously they would be tissue mediated, the macrophages and cytokines mediated immune response, and it will cause the either the direct damage to the tissues by Escherichia, or it would be immune mediated response. So there would be inguinal and axillary lymphadenitis. There would be lymphangitis, and there would be cellulitis, abscess formation, and ultimately ulceration. And if we do the histological evidence for that, there would be funiculoepididymoorchitis as well, and the patient will develop scrotal swelling as well. So always remember the clinical features for the acute filariasis would be fever, would be headache, malaise, there would be inguinal and axillary lymphadenopathy, and there would be inguinal scrotal swelling, there would be cellulitis, abscess formation, and ulceration, and there would be lymphadenitis or lymphangitis. Talking about the chronic features of the chronic filariasis, there would be lymphoedema of the legs. There can be presence of the hydrocele, as told you, there would be inguinal scrotal swelling, and there can be abdominal and the lymphatic varices at times, and if you're doing the inspection in such patient, it would be quite visible to you. There can be chyluria and there can be lymphouria, and I would say there, if you compare it with the there's a normal urine, and if you compare the normal urine would be there would be whitish urine with a consistency having the lipids, and there can be a lymphouria because of the chronic filariasis. There's another condition which is called endemic elephantiasis. So sometimes in case of filariasis, there can be massive distension, or there can be massive filariasis, or the swollen limbs. But there's another condition which is called as endemic filariasis, and you can actually see it here. And if we talk about this, it is the culprit behind this is the silica or the silica particles, and it's more common in the African population. So those people who are particularly in Africa, and they're working with the soil, and they're more of the time they have a kind of the occupational exposure to agriculture somehow, and they're working in an environment in which there's a volcanic eruption. So in those areas, there's more of the particles, the soil is enriched of the silica particles. And whenever these people, they walk barefooted on that soil, actually the silica particle, they get absorbed, and because of that, the silica is kind of very, very damaging to the lymphatic channels. So this is the extensive involvement, and you could appreciate that there's an extensive fibrosis, there's a gangrene, and with the lymphatic, not only the obstruction of the lymphatic channels, but actually they ultimately develop the chronic venous insufficiency. And because of that, the patient would ultimately develop the ulcerations that you could appreciate, and the patient will develop the gangrene as well. Why do we call is as endemic elephantiasis? Because it's generally involving the broader population, especially the African population, or especially those patients who are some kind of occupational relationship with the soil and agriculture, in which there's a volcanic eruptions, or they have some kind of relationship with the silica particles, and they walk barefooted, and because of that, there's absorption of the silica particles into the body, and ultimately they lead to the lymphatic obstruction and direct damage to the lymphatic channels. So how you are going to treat the particular condition of that lymphedema? So the secondary lymphedema is like you have to treat the condition. Sometimes we'll be talking in detail investigation and management, but for now you should remember that obviously you have to counsel the patient. You have to give a kind of the occupational awareness to that particular group of the people, and you should ensure that the people who are working in such kind of environment, they should not walk barefooted, and limb elevation and limb exercises and kind of the phototherapy, that's kind of helping, but we'll be discussing that in detail in the next lecture. But there's some conditions which are actually mimicking lymphedema. So briefly, we would be describing that conditions, like there can be a fictitious lymphedema. Sometimes, there's some kind of the psychiatric problems, and they usually feel happy when they kind of give a self-harm to them. So what they do is actually, in case of fictitious lymphedema, what they do is they apply a tourniquet, or some kind of they tie the cloth around their legs, and because of that, it's a kind of a self-harm because of the psychiatric illness and the psychiatric problems which they're dealing with. So because of that, they apply the tourniquet on their limbs. Either it can be lower limbs or it can be upper limbs as well. So because of that, there would be stasis, and the patient will develop a kind of the swollen limb. So it's a kind of the condition which is actually mimicking the lymphedema. So talking about that, what we talked recently is the fictitious lymphedema, and sometimes these patients, they are usually remembered those patients who have some kind of the psychiatric problem, or they're dealing with some kind of anxiety or depression. And ultimately, what they do as a result of that, they give a kind of a self-harm to them, and they apply a tourniquet, or they try to put some clothes tightly, and because of that, they feel happy to do that. But as a result, they develop the swelling of the particular organ or the particular limb. Immobility. All those patients who are after amputation, or kind of the orthopedic surgery for a very, very long time, and the patients especially who develop stroke or quadriplegia or paraplegia, So because of that, they're unable to move. So immobility is kind of another thing. It can be a factor for developing the lymphedema, or it can be a kind of the condition which is mimicking the lymphedema. Now, how you are going to differentiate? You're going to do the lymphangiogram, and on lymphangiogram, if there's some kind of obliteration or kind of hypoplasia, dysplasia with the lymphatic channels, then obviously you will think that immobility was the cause behind that. But sometimes if there is normal or near normal lymphatic filtration, or a kind of the lymphatic channel, so normal lymphatic channel, so then you would be thinking that this swelling is because of immobility, and because the drainage against the gravity, and the patient is immobile, and there was a stasis. So these are the conditions which are actually mimicking the lymphedema. So there's another condition which is the lipoedema. So the lipoedema is actually the excessive deposition of the fat in different parts of the body. In lipoedema, it's some kind of, it's usually involving the trunk, the thighs, and sometimes the lower limbs as well. You need to differentiate lipoedema from lymphedema, because in lymphedema there would be some kind of problem with the lymphatic channels. There would be obliteration, or there would be destruction of the lymphatic channels. So in this particular category, in lipoedema, there would be excessive deposition of the fat, and mostly it's common in the people who are very obese, and it's involving the distribution would in case of the lymphedema, the usual involvement is the swelling would be restricted to the foot, or restricted to the lower limb or the lower legs. But most commonly, in case of the lipoedema, they would be swelling of the thighs, or they would be swelling the trunk. Now, this is important to differentiate the lipoedema with the lymphedema as well, and lipoedema. So you should always remember that lipoedema is mostly common in the women, and especially those women who are actually obese. Now, there's another thing, which is the edema is pitting and non-pitting, right? So sometimes when you're examining the patient of a secondary lymphedema or a primary lymphedema, and you try to press harder on that edematous surface, and there's a formation of the pit, then that is the lymphedema. But if there is no pitting, obviously the fatty tissues they do not produce the pitting, right? So in case of the lipoedema, there would be more of the extensive deposition of the fat. So because of that, there would be no pitting when you're trying to press the surface. But if you do the MRI, so MRI would show that there is subcutaneous fat, but there is no fluid accumulation. Another thing which is important to know, that it would be kind of a bilateral, and it would be symmetrical. Most of the time the lymphedema is unilateral. It can be bilateral in case of the congenital cases, but usually it's in case of the adult population, it's unilateral and it's asymmetrical. But lipoedema is usually bilateral, and it's symmetrical as well. So the onset usually coincides with the puberty, because of the after puberty there is some kind of difference in the hormonal levels, and most of the time the estrogenic hormones, or even the steroidal hormones, or the testosterone, they're mostly the steroidal in nature, and most of the time they produces more of the deposition of the fatty tissue on the subcutaneous plane. So their onset usually coincides with the puberty. There would be involvement of the trunk as compared to the lower limbs. Feet particularly, they're not involved, but if you compare it with the lymphedema, then there would be involvement of the foot, and there would be pedal edema. That would be the first sign in case of the lymphedema. Or inverse shouldering effect at the malleoli. Now, what does that mean? Usually, in case of the lymphedema, usually there is a kind of more of the lymphedema at the malleoli. And if you could remember my previous lecture, I already told you that because of the excessive deposition of the fluid or stasis of the lymph around the malleoli, there would be an appearance of the buffalo-like feet. But this typical effect would not be present in case of the lipoedema, which is called as inverse shouldering effect at the malleoli. So there would be no edema at malleoli, but there would be edema around the shin or the thigh, or the truncal involvement would be there. And no response to the elevation or compression. So it's somehow very, very much important to differentiate the conditions that are mimicking with the lymphedema. Like, you need to investigate a case properly, start from the history, ask for the conditions of the malignancy, or ask for the radiotherapy or some kind of bacterial or fungal or the parasitic infections, or ask the patient about some kind of excision to the lymph node, or some kind of axillary dissection, or the breast surgery, mastectomy properly. And you have to differentiate the conditions like the factitious lymphedema, in which more common in the psychiatric patient, and they're usually as a result of the self-harm or applying the tourniquet to their limbs. Or you have to differentiate with the immobility generated edema, or you have to differentiate a lipoedema from lymphedema. So lipoedema is more common in the women. It's usually bilateral, it's symmetrical, and the distribution is usually on the thigh and the shin, the proximal part of the leg, and the trunks as well. And there would be the history of obesity as well. And obviously the patient will typically tell you the history that most of the time there's a correlation with the puberty. The patient will typically give you the history that I developed this edema after a particular age. So age of the onset is somehow very much important, and the distribution is somehow very much important, in which the feet are usually spared, and because of that there is inverse shouldering effect at the malleoli. I have already explained that. And another thing which is important is like in case of the lymphedema, if you put the compression stockings, or if you keep the legs elevated, there would be a kind of improvement in the lymphedema, but there would be no response in case of the lipoedema. And if you do the MRI would typically show the presence of the fat, but there would be no fluid accumulation. And last thing which is somehow important is sometimes in case of the lymphedema, in which a chronic venous insufficiency later on develop, there would be skin changes as well. There would be dermatitis, there would be ulcerations, there would be dermatophytosis. But in case of the lipoedema, there would be no societal skin changes. So keep these things in your mind, and that's how you can differentiate between a lipoedema and the lymphedema. So that's all for today's lecture. So mostly we focus on the clinical features and the classification of the primary and the secondary lymphedema. We also talk a little bit about the specific conditions like the filariasis, like the endemic elephantiasis, and some of the conditions which are actually not the lymphedema, but they are mimicking or giving you the impression of the lymphedema. Somehow the investigation and the management of these conditions is very, very much important, and I have reserved that for the next lecture. So thank you for today, and keep watching sqadia.com, Dr. Sana Khan, General Surgery course.